Welcome to the SCI Forum podcast. This podcast was produced by the Northwest Regional Spinal Cord Injury System in the University of Washington Department of Rehabilitation Medicine. The Northwest Regional SCI system is dedicated to improving the lives of people with SCI through excellent patient care, research, and education. To learn more about our podcasts and videos or to make a donation, go to sci.washington.edu.
Hello and welcome to the Spinal Cord Injury Forum podcast. My name is Jeannie Hoffman and I'm the director of the Northwest Regional Spinal Cord Injury System and a clinical psychologist and professor in the University of Washington Department of Rehabilitation Medicine. As part of our series on the therapists who work with people who have had spinal cord injury, I am joined by Jordan Cabrera. Jordan is a physical therapy clinical specialist at the Comprehensive Outpatient Rehabilitation Program, fondly known as CORP, at Harborview Medical Center. Jordan, thank you so much for joining me today.
Thanks for having me.
So I'd love for you to just tell me a little bit about kind of how do you become a physical therapist? How do you become a physical therapy clinical specialist?
Yeah, so to be a physical therapist, nowadays it's a doctorate degree. So someone has to get their bachelor's degree and then go to graduate school and to become a physical therapist. Back in the, maybe the 80s, it was a bachelor's degree, and then maybe in the 90s it transitioned into a master's degree, and since the early 2000s it became a doctorate degree. And so during someone's education in school, they'll have clinical internships while they will work in different settings, outpatient settings, inpatient settings, schools, nursing homes, things like that, and then they graduate. Some people tend to want to get more specialization, and so once they graduate from school, they may decide to apply for a residency. When I graduated, there weren't as many, they weren't as common, but nowadays residencies are pretty common where PTs can gain more specialization in a specific area. So spinal cord injury kind of is under the umbrella of neurological physical therapy, and so when I graduated, I decided to work at a facility that had a big spinal cord injury unit. It's called Mount Sinai Hospital in New York City, and so that's where I gained a lot of my initial knowledge of spinal cord injury. I started in an inpatient rehab unit and then started working in an outpatient. And then when I moved over to Seattle and worked at Harborview, I started there as a physical therapist in the outpatient setting. And so being in the inpatient side really helped me learn and refine my skills as a PT. It was a great way to come full circle.
Yeah, great training experience too, both having kind of the full spectrum of from early to long, lifetime care for spinal cord injury.
Mm-hmm.
What made you interested in the spinal cord injury populations? What was it about that made you go, oh, this might be a good fit for me?
Yeah, well, I was actually trained and educated on the East Coast in New York City, but then I am originally from here, so I actually did one of my internships at Harborview Medical Center, and so that actually started my passion for spinal cord injury and for the neuro population in general. So I had a great experience when I was an intern at Harborview, really learned a lot about neurological trauma, and that started my interest and my passion for the area.
So when you do an internship, do you have to do like an extra training beyond that, or is it just really that internship gives you that kind of insight and then you just have to go get like continuing education, or how do you become a specialist with spinal cord injury?
So for people who really want to specialize in a neurological setting, they can apply to do a residency after their entry-level education as a PT, and that's usually another year afterwards. And a lot of the major centers, neurological rehab centers, have residencies, and so those are kind of the main routes. Some people choose to just work at a place that has a lot of that population, and some people do those residencies. I was lucky enough to work in places that saw a lot of spinal cord injury patients and did a lot of SCI care. So I started my career there in Mount Sinai, and so that kind of got my foot in the door, and then I was able to gain a lot of experience
Yeah, so I
in the
was going to
field.
say the same thing that you would get if you had done the residency program, but
Hmm.
probably somewhat even better because it's
Hmm.
even more targeted just to spinal cord injury.
Yeah,
Yeah.
yeah. Luckily, I was able to work in a SCI unit, and then saw SCI every day, and then transitioned to an outpatient setting. So that really helped my learning about rehab and adding to my toolbox.
What is the role of a physical therapist? What are the kinds of things that you're working on with patients from the time that they are initially injured? So, kind of, what are the usual things you do on a day-to-day basis with someone?
So our goal in physical therapy is really to work on functional independence and helping patients with their needs for that, and also needs for equipment and just staying healthy. And so what we'll do is we'll look at, based on their level of injury, what they need to learn to become independent. So we'll look at their bed mobility, how they move around in bed, how they're able to transfer, getting out of bed, getting into a wheelchair, or just walking or standing, all those good things. And then we'll also look to see what is the best way for them to be independent with mobility. So if it's walking, if it's using a power versus a manual wheelchair. And then we often will teach exercises, for them to do on a daily basis to make sure that they stay healthy.
Yeah. It's a broad range then with people with
Hmm.
spinal cord injury because it could be from the level of somebody who really can't move arms or legs and needing to get them into a wheelchair up to being able to get back up and walking.
Exactly. Yeah, and so a lot of times we're looking at the type of equipment they may need to make them as functional as possible.
Mm.
And so that's a big part of what we do. At Harborview, we have a seating clinic, so we look specifically at wheelchairs, but also just walking equipment as well.
That reminds me about just how much seating is such a big area. And I think
Hmm.
that is sometimes also split with occupational therapy too, physical therapists and occupational therapists. But is that, I mean, a seating specialist is really what you need, somebody who has expertise in knowing what kind of cushion, what kind of surface, all
Hmm.
those kind of pieces, right? And it's not just your seat, but also your back as
Hmm.
well, like your posture and all those things, right?
Yes, definitely. Yeah, so seating specialists can be physical therapists or occupational therapists. It really depends on the facility, but both therapists can be wheelchair specialists. And so it definitely is a whole system. So when we look at seating, we look at not only the frame or the base of the chair. So frame if it's a manual chair, or the a base if it's a power wheelchair. But we also want to make sure that someone has the correct backrest, because we want to make sure that they don't have postural issues that can lead to deformities over time. One example of that is a scoliosis. If someone is consistently, shifted to one side laterally, that can lead to a curvature in the spine over time. And so we try to promote as much of a midline posture as much as possible. So we'll often decide on a specific backrest to make sure that their posture is good. We also want to look at their cushion. There's so many different types of cushions out there, different products and different materials. And so we will, and there's not one cushion that's better than another. So we will definitely help decide on the correct cushion for a patient to be as functional as possible, to have good posture, and also to protect their skin at the same time. And then on top of that, as you know, the wheelchairs can have a lot of different components that we will help decide. It can be the wheels, it can be the foot plates, it can be the headrests, it can be the way that someone's driving the wheelchair. As you said earlier, that there can be individuals who are driving a wheelchair through their head or through their chin, or in addition to their arm. So we really want to we really try to be thorough and have good evaluations to make people as independent as possible.
So, how much does that change once you go from an inpatient hospital stay to what you're doing now on an outpatient basis? What are the differences, or does it all kind of fall into that same range of activities?
It depends on the patient. What we look at is, as we know, there's different levels of spinal cord injury. So where it is in the spine that's injured, and also their level of completeness. So if someone has more has a complete injury, we may be looking more at compensatory strategies. And what I mean by that is having them do things in alternate ways or alternative ways. For example, if we're teaching a patient to go from, to sit up from bed, we may teach them to use their arms, something intact, to move their legs for them. Versus someone who's incomplete, we may teach them more restorative strategies and also some compensatory strategies to see like what will make them most independent. If we can restore us function as normal as possible, we'll try to do that. But it really depends on the type of injury they have and what's available.
So one of the things that has been changing a lot over time is length of stay in the hospital. Do you see that people are getting more outpatient therapy because they're not able to get as far as they did during inpatient as they used to? Or do you feel like therapy still doesn't kind of do they have to do more things on their own?
Well, yeah, I definitely think that there's limitations on both ends, on the inpatient side and the outpatient side. Back in the day, I know patients with spinal cord injuries could be in an inpatient rehab hospital for several months, even as long as 6 months, sometimes a long time ago. And now it's very limited to maybe 1 to 2 months, depending if they have tetraplegia or paraplegia. And so I do find that there is more of a push to try to shorten the length of stay. And so in the inpatient setting, patients are there for more intense rehab. So they're seen 3 hours a day. They're given 3 hours a day of therapy. And so with the limitations with insurance, a lot of times patients are pushed out sooner, which makes it difficult. We're doing some interventions as an outpatient, which used to be done as an inpatient. But sadly, there are also limitations in outpatient. So many people may get as little as 12 visits, after a spinal cord injury. So what we end up doing is really strategizing and seeing if we can spread out those visits. And then we definitely give a lot of the ownership to the patients in the outpatient setting, or even at least assistance, having them get assistance from their families or from caregivers. So we definitely want them to do as much as they can on their own, and then we may see them, once or twice a week, and then have them kind of guide them through that and progress their exercises, and kind of help them with equipment that may make it easier to do at home. For example, like a standing frame, we may try to get that from insurance, and then see if insurance will pay for it, and so they can do a lot of that stuff at home. But it can be difficult because we are really trying to spread the benefits as much as possible.
Yeah. I got a couple follow-ups on that. One of them is, are you noticing, is this impacting people's ability to be as independent as they used to be? Do you think that it actually changes? I've heard people sometimes say that, now people are staying in power chairs when they used to be able to get to a manual chair level for some types of injuries. Or do you feel like it's just shifted? Maybe it takes longer, or it shifts the onus to the person with spinal cord injury, or do you have a sense of that?
I do think that there is a shift that's happening a lot of times because patients are being sent home earlier than before. We may not have the sense of where their injury will be later on. So they may be given equipment that may not be needed later on. But I think that's our goal is really to keep them as safe as possible. So if someone needs a power chair when they get out of rehab, and then in outpatient, we may progress that and see if they can progress to a manual chair, or maybe into walking, depending on what the prognosis is. Does that hopefully answer your question?
Definitely. It sounds like it's maybe more into equipment rather than that people aren't necessarily making the progress. Might just be happening over time.
Yeah, and it's why we like to spread out our visits, because if we use all our visits earlier in the year, and then we can't see those patients after a while, and there can be a lot of change in the first year after a spinal cord injury, and we want to make sure that we're there to kind of guide them through that process.
So the other part of that is just the kind of lifetime care for people with spinal cord injury. I mean, I know that wheelchairs, end up kind of breaking down over time. People get new injuries, new other problems. But is there kind of a regular thought that you have about like how often people should be touching base with a physical therapist over the course of their life with spinal cord injury?
A lot of it depends on the patient's insurance and the goals. So after a spinal cord injury, we'll see a patient pretty regularly, and then to meet their functional goals and to help connect with them to if needed wellness activities or give them equipment to be as independent as possible. And then after we've met all our functional goals, we may discharge a patient and then wait till either they may have gained more progress later on, or let's say they have goals later on they want to attain, and so we may see them again. Or some patients come back just because of equipment needs. So a lot of insurances will pay for wheelchairs every 5 years or so. So we'll see them again for a new wheelchair. But then a lot of it has to do with the needs of the patient, and that can just change over time.
Mm-hmm.
But we definitely see patients pretty regularly throughout the years, especially in an outpatient setting. But we really try to keep it as functional as possible, and to see what their needs are.
Can you give me an example of somebody who, thinking about like 20 plus years post-injury that you've seen recently, without giving any details, but like what did they come back for? What was their need for physical therapy?
Yeah, sometimes we have patients, maybe not 20 years down the line, but even just who've met their goals at the time for initially after their injury, and then they get discharged, and then they continue to work at getting stronger. Some patients will go to like a wellness programs that work with patients for exercise, and so they may, or let's say patients have their own program that they do on their own. They get stronger, and then they feel more ready to do more advanced skills. So some advanced skills could be like a floor transfer, so being able to get up from the floor to the wheelchair, and that's a skill that's really difficult for a lot of patients. And so some patients aren't ready initially, but they may be ready later on. Some patients may need a tune-up, and sometimes they feel like they're kind of falling off their program, and so they want to need a review of what they should be doing on a regular basis.
Yeah, develop some bad habits.
Yeah, exactly. They need to just little nudge, little reminders of the types of exercises they should be doing on a daily basis. So we'll see them for that, and kind of re-educate them on their exercises and things that they should be doing to stay healthy. Because nowadays it's we're really pushing for patients to be as healthy as possible. It's not just about staying functional, but it's also staying as healthy with exercise and physical activity, and incorporating that into their regular daily life.
Yeah, that's great. I think that, I certainly know that like our rehab department is really focused on exercise as medicine. And so I'm assuming that's true for all of our population, not just healthy people aging, but also individuals with spinal cord injury and other disability.
Yeah, because it can be really hard if someone is in a wheelchair on a regular basis to get that physical activity in their daily life. So we definitely help individuals find ways to do that, if it's through a wheelchair or from walking, or even using a electrical stimulation bicycle, things like that. All those, there's a lot of different ways that we can teach patients to exercise.
Yeah. Do you also, back to the kind of aging question, do you find that people with spinal cord injury as they age maybe need different equipment or different tools? I'm thinking about some interviews we did a few years back where we talked to people aging, and there was a few people who switched from being manual wheelchair users for many years to really needing power chairs. Do you see that very often or not too often?
Yeah, we actually see that a lot, especially as individuals age. It can be, their joints can get arthritic or can break down over time, or people can get overuse injuries, such as tendonitis or just a lot of chronic pain. And so for people to be more independent in their everyday function, or to be as mobile as possible, they may choose to switch to a power chair. also that can be also said for spinal cord injury patients who are able to walk with bracing or with assistive devices like walkers or canes. They over time as they age, they may decide to use a wheelchair more often because of the joint pain or just because overuse injuries. Yeah, I see that quite often, so it's pretty common.
So I was going to say another kind of lifetime role for physical therapy.
Yeah.
So, we're going to be talking with occupational therapists and recreation therapists and things like that. Where is the overlap? Like, it seems like sometimes on the inpatient unit, people aren't always clear about kind of how many things that the therapists do alike and then what things they do differently. Do you kind of have a way of describing kind of what is physical therapy versus some of the other therapists?
Yeah, I think all of us, so all the therapies, we all have a similar goal. Like we want to make patients as independent as possible. And so in spinal cord injury, a lot of those things, like interventions we use, do overlap. For example, as a physical therapist, I'm focusing more on a patient's ability to perform, gross motor activities, or like being able to get from out of bed into a wheelchair, walking or using a wheelchair, all those activities. And then, OT, for example, will focus more on seeing if they're able to perform a lot of activities of daily living on their own, such as dressing, grooming, and bathing, and some foundational things such as balance or strength, are needed for both tasks, right? So, for example, for balance is one common one, right? So if I'm teaching a patient to be able to transfer into a wheelchair, or if they need to stand to walk, I'm focusing on balance activities. And so in a OT can also focus on balance, but then integrate that into their ability to go to the bathroom or to brush their teeth or to do grooming activities, things like that. So there is some overlap in that, but then ultimately we really just our focus is to gain as much independence as possible, just in different ways.
Yeah.
So yeah. And then same thing with recreation therapy. A lot of times recreation therapy is focusing on some of the like adaptive sports or some of the community activities. And so to do that, they need to be able to use a wheelchair or be able to walk or mobilize. And so we'll do a lot of preparation to be able to get our patients to that point. So.
Yeah, that's great. And I'm sure, and it seems like at least on inpatient rehab, like the nurses really follow the lead of therapists in terms of kind of extending the work of transfers and things like that into off hours, off therapy hours. Yeah. So quite a bit of overlap in there. So what about what you do makes you happy to go to work every day?
Being a physical therapist, it's really rewarding for me. That's just why I chose this specialty. I honestly, when I first started PT school, I thought I would be doing more orthopedic sports medicine type PT, like the type of PT that most people think of. But then it was truly my internship at Harborview that really changed my perspective on things, and I really found a lot of joy in helping people adapt to their new life, and really I found it really rewarding. Individuals are, their life can change in an instant, and so it's really great to be part of their recovery and to help them gain as much as they can.
So what is the lifespan of a physical therapist who does neuro PT? Is this something you can do through your whole life, or is this something that gets hard physically as you get older?
Yeah, it definitely can be difficult as you get older. When I worked on a spinal cord injury unit and saw all SCI 8 hours a day, 5 days a week, I definitely I was in my 20s, and so I had a lot of stamina and energy, and so seeing patients when they're newly injured, I did a lot of transfers and did a lot of gait training, and just where I had to really use my body to, and I try to be as safe as possible with my body mechanics to so I don't get hurt. But yeah, I think over the years being an outpatient, it's a little better, and an outpatient are a little better with mobility, or can be sometimes. So yeah, I think for now it's a good fit for me. But then over the years, some physical therapists decide to kind of get out of patient care or decide to do something that's not as hands-on. For me, it takes the fun away from it. So hopefully I can stay in the neurological setting as long as possible.
Yeah, I was going to say there's definitely lots of things to do, and it sounds like outpatient does make it a little bit less of the intensity as you might get it on an inpatient rehab unit.
Yeah, the great thing is that, as you said, spinal cord injury there's such a big variety. Some people, depending on their injury, depending on their level of completeness, there are patients who present differently, and so it's kind of fun to be able to work with individuals who may need a wheelchair, who may not, who may need a assistive device to walk, or there's a lot of different things you can do with patients. So I think it keeps me on my toes and it makes it fun.
I was going to say, it just seems like, I'm just sitting here as you're talking, thinking about you go from patients who are completely dependent on ventilators, who you're teaching to drive with their mouth, either using some sort of a head array or things like that, to somebody who's basically ready to be up and walking again, and everything in between. So
yeah, definitely. It's like trying to solve a puzzle every day, so and see what works. And every patient can respond to interventions differently, and it's very neurological physical therapy is very it's not cookie cutter at all. It's not protocol driven, so it's very much as trial and error sometimes, and seeing what works best for each person and seeing what makes them the most successful as possible.
Yeah, I think that's, it's so interesting because there's just no two injuries that are exactly alike, even if the level is similar. That's great.
And I do love the team aspect of it as well. We work so closely with occupational therapists, recreation therapists, speech therapists, nursing, doctors, and then psychologists, of course. I was going to say that the most, and so I love the team aspect of spinal cord injury care, and so it provides a great environment where we can really put our brains together and help each person, because everyone's different, and so we want to tailor everything to a person.
So you mentioned kind of the recovery versus compensatory stuff. Can you give me some examples of what you mean when you say like compensatory strategies?
So some of the strategies we'll do in physical therapy really is based on a person's level of injury and also their level of completeness or incompleteness. A lot of times we'll use compensatory strategies or restorative strategies, or a combination of both. Typically with our complete injuries, we tend to do more compensatory strategies, and an example of that could be doing a transfer. If someone does not have enough leg movement, that we may teach them to use their arms to move their legs, or use devices as leg lifters, things like that. We also, even just teaching someone to use a wheelchair, that's a form of a compensatory strategy. But if someone has more of an incomplete injury, we may teach them to do a combination of restorative strategies and compensatory. We might really try to get them we'll do some walking, gait training. We may use an electrical stimulation bicycle to really try to strengthen the legs, or improve their endurance after a spinal cord injury if they have some movement. And so a lot of those types of interventions is really based on the person. And so our goal ultimately is to really try to make them as independent as possible, and then really make them as functional as possible. Some patients may be able to walk indoors, but then that may not be good enough in their everyday life, and they may want to be able to use a wheelchair part of the time, to get from point A to point B, and then still be independent and still be able to carry on with their lives. So
that's great. I'm going to put in a plug here because we had a great panel on when to walk and when to use a wheelchair. So there's a great panel on video and probably podcast coming soon on that.
Yeah, and those are good discussions to have, because if someone is able to walk But if it's really causing them to have a lot of pain, or if it's causing an increased risk of overuse pain or arthritis, things like that later on in life, then we want to try to preserve their shoulders, preserve their joints as much as possible. So we kind of want to have a good balance of having patients as active as possible, but still thinking about the long-term plan of preserving their joints and their bodies, right? Because a lot of patients use their arms, for example, a lot, and then that can increase their risk of injuries.
Yeah, well, and we met somebody recently that had to have shoulder surgery, and that led to them having to live in a nursing home for a period of time because they couldn't get up and use their wheelchair. And so I think all of those injuries could have a really big impact on people's ability to live their daily lives.
Yeah, so we definitely do a lot of education in that to talk about joint preservation and knowing when they should walk, when they should use their muscles with their activities, or if they should decide to kind of use something and a more compensatory strategy. And so it's a good discussion, because I know a lot of individuals want to be as active as possible, but we want them to think about the long term.
Right, their long-term health.
Yeah.
So on an outpatient basis, what are the things that kind of end up being urgent referrals to physical therapy? What are the things that it's like, do not continue, get to physical therapy immediately?
So one really good example is a skin issue. A lot of times when individuals are transferring, or when they're in a wheelchair for long periods of time, they can get a pressure injury, and spinal cord injury patients are at high risk of that. And so when someone has a pressure injury, it's going to be really good to see a physical therapist to make sure that the equipment is adequate, making sure that there's nothing wrong with their cushion, for example, or even seeing if there's strategies that they can do to avoid the pressure injury. For example, if someone is rubbing their buttocks on a tire when they're transferring, and if that's causing an injury, then we want to teach better, good habits and teach good transfer techniques. That's an example of an urgent issue that I think patients should see a PT right away.
Yeah. So for you, somebody who has worked with you and leaves successful, what does that look like?
That's a good question. I think it's really if patients have met their goals and is happy, and is satisfied. I think it's, even if someone has the potential to walk, to be independent with an activity, if it's not meaningful to them, I think it can be difficult to spend all this time in physical therapy for that activity. So I really try to tailor what I do to what is important to the person, and then really try to educate them on healthy habits and just staying healthy over time. And so for me, if someone is healthy and happy and making good choices, and I really feel that's a successful outcome.
Yeah, that's great. Jordan, thank you so much for joining us today. This has been really wonderful, and look forward to continuing to work with you.
Yeah, thank you. It was my pleasure to being here.
Thank you for listening to the SCI Forum podcast. To learn more or to make a donation, please visit sci.washington.edu.